Now I want to ask Dr. Salman Sharif and Sandeep Vaishya to moderate the next session on management of spinal degenerative disorders.
Before
Welcome.
we start, Mehmet, I'm going to say really this webinar was so good. I was enjoying I was there connected for last 15 minutes and I really enjoyed it. So I'm grateful to all the speakers and I think brilliant, good discussion. I think in every way it was very good. Sandeep, you want to go first and introduce?
Yes, please.
Unmute yourself, Sandeep, please.
Yeah. Hi, everybody. So we are already 10 minutes late to start, so we'll just start it. And the first speaker would be Yeşim Kirazlı, who will be speaking on conservative management on spinal degenerative disorders. Is the speaker here?
Yes, I'm here.
Okay.
Just
So
one moment.
you can share your screen.
You can just click the share screen button in the
Yes, I did it, but
bottom of the screen. Good, very nice.
tamam sunuyoruz. Beni de kaldır istiyorsan. Dear Chairman and dear attendants, many countries, especially developed ones, have been facing rapid population aging. As the population ages, the incidence of degenerative spinal disorders increases, and they can cause pain and disability, and also lead to secondary health issues such as cardiovascular diseases and mental health disorders. Therefore, early treatment to improve the healthy life expectancy of people is crucial. And spinal degenerative disorders coexist with other diseases. For example, sarcopenia is associated with poorer quality of life after lumbar surgeries. And the results suggest that diabetes is a predisposing factor for lumbar spine disorders. And spinal degenerative diseases and osteoporosis often coexist in the elderly. Therefore, addressing spinal disorders and some other diseases often requires a multidisciplinary approach. I would like to address the first question now. When is it possible to apply conservative treatment? North American Spine Society formed some clinical scenarios to determine the appropriate multidisciplinary treatment recommendations for degenerative spondylolisthesis. And they concluded that physical therapy was appropriate in most scenarios and most appropriate in patients with back pain and no neurological deficits. And other researchers included lumbar stenosis patients, which is the most common cause of spinal surgery in the geriatric population, and they concluded that physical therapy and rehabilitation play an important role in the treatment of lumbar stenosis. Physical therapy is the primary treatment option for patients who do not have motor muscle strength losses and incontinence and who have pain control through medications. And how is it possible to apply conservative treatment? I would like to provide you the evidence for bed rest, lumbar support belts, exercises, instrumental physical therapy modalities, manual therapy, and acupuncture. Bed rest avoiding bed rest and staying active are recommended all through the guidelines, even in acute low back pain. Are lumbosacral orthoses is harmful? And several studies show that they are not a case of uniform deconditioning as is suspected, and they don't result in trunk muscle weakness. But as an opinion, it is better to recommend them in acute back pain and not in chronic back pain for long durations. There are lots of kinds of therapeutic exercises, such as core stability, balance, McKenzie, aerobic, aquatic, stretching, and strengthening exercises. And interestingly, in the last years, exercises such as yoga, which helps to people for well-being, are included in clinical guidelines. And there is no clear evidence of the superiority of one form of exercise training intervention over another. There are a large number of randomized controlled trials examining exercise interventions, but there is a high heterogeneity. And fortunately, no studies reported harm from exercise training interventions. As a recommendation from all guidelines, physical therapists should use exercise training interventions, including trunk muscle strengthening and endurance, multimodal exercise interventions, specific trunk muscle activation exercise, aerobic and aquatic exercise, and all general exercises for patients with chronic low back pain. TENS, transcutaneous electrical nerve stimulation, is an instrumental physical therapy agent. In a meta-analysis, which includes almost 400 randomized controlled trials, the findings suggest that it may be beneficial for pain irrespective of pain characteristics, acute or chronic, it doesn't matter, or medical diagnosis, back pain or others, it doesn't matter. Supporting the view that TENS should primarily be indicated according to symptoms, that is, the presence of pain rather than medical diagnosis. The findings supports TENS to self-administer as a strong, non-painful, within or close to the site of pain, and to adjust pulse frequency, duration, and pattern to what is most comfortable. Patients are advised to administer TENS as often as necessary, and it could be used at home. A subgroup of patients with signs of nerve root compression, along with peripheralization of symptoms or a positive crossed straight leg raise test, will benefit from intermittent lumbar traction. But on the contrary, there is moderate evidence that intermittent or static lumbar traction should not be used because it will not be helpful for reducing symptoms in patients with non-radicular low back pain or in patients with chronic low back pain. Massage is a Cochrane analysis in 2015, and after that date, no randomized controlled trials for massage was performed. All kinds of low back pain had improvements in pain outcomes with massage, and also there was functional improvement, but these improvements were in short-term follow-up and only minor adverse effects. Manipulation and mobilization as manipulative therapies may be used in acute and chronic lumbar pain, but they only provide short-term improvement up to 6 weeks. There is evidence for acupuncture, moderate evidence. Acupuncture could be used in patients with acute and chronic low back pain, and significant effects were demonstrated with respect to pain intensity, but not function. There were only minor adverse effects with acupuncture. According to American College of Physicians, there was this recommendation. For patients with chronic low back pain, clinicians and patients should initially select non-pharmacological treatment with exercise, multidisciplinary rehabilitation, acupuncture, mindfulness-based stress reduction, Tai Chi exercises, yoga, motor control exercise, progressive relaxation, low-level laser therapy, cognitive behavioral therapy, and manipulation. And Zhu tried to perform a global comparison to identify and compare the recommendations of recent clinical practice guidelines. A total of 22 clinical practice guidelines met the inclusion criteria, and they were of middle and high methodological quality. If we look at the commonality of recommendations for chronic low back pain, blue lines show the agreement between the clinical guidelines, red disagreement, and purple means not mentioned. And we see that bed rest is prohibited during the clinical practice guidelines. Staying active, the blue line is high, and the other blue lines which are high is for the therapeutic exercise, cognitive behavioral therapy. And if you look at physical therapy agents, which are heat therapies and analgesic stimulation, we see that it is purple. That means there are not enough studies, randomized control studies.